Beautiful. Hello, my name's Liz. I'm a clinical psychologist, and for most of my career I've worked clinically in drug and alcohol services, most frequently with methamphetamine use, and I've only fairly recently entered the world of psychedelic-assisted psychotherapy as an investigator and therapist on the SIMAR trial, which has been recruiting out of St Vincent, Sydney, for the last 12 months with funding from NCCRED. All right, so these days, psychedelic-assisted psychotherapy rarely needs the introduction that it once did. So in the interest of time, I guess the one piece of background information that I really want to get across the most is to reinforce just how early our understanding is of efficacy, but even safety and feasibility in this type of treatment. So this is particularly important given the TGA's controversial rescheduling of psilocybin-assisted psychotherapy for treatment-resistant depression only earlier this year. But there is so much more to be interrogated regarding potential negative outcomes and risks, mechanisms of action, and even that's before we get to the psychotherapy itself, which hasn't been studied at all. So the SIMAR trial is the first of its kind, and our aim is to examine the safety, tolerability, and feasibility of psychedelic-assisted psychotherapy in an outpatient addiction setting to adults with methamphetamine use disorder. It's an open-label, single-arm design, and we were hoping to get 15 participants recruited, and we'll be measuring our outcome through patient report, the all-important adverse event reporting, looking at numbers through the study, and consideration of resourcing. So the intervention itself is made up of 3 PrEP therapy sessions. They're about an hour and a half to 2 hours in length each with 2 therapists, all therapies completed in a therapy dyad. The dose day is approximately 8 hours, again in the therapy dyad at all times, with an administration of a 25 milligram dose of psilocybin. And then we have 2 integration psychotherapy sessions, the first the immediate day after the dose day and the second a week later. Study visits include the 3 screening visits, a pre and post qualitative interview, and regular follow-up visits to 90 days. Our initial pre-screen was accessed via an online survey or a phone call. So out of 57 who were pre-screened, 17 were deemed eligible and 15 have been consented and recruited into the study following the 3 screening visits. Of the 15 that were recruited, 12 have currently completed their intervention, and we've got 2 more scheduled to hopefully begin in coming weeks. So I've got some details here of the 15. Perhaps of most importance is number of days methamphetamine use per month. We did start with an inclusion criteria of less than 16 days per month early on, but once we had 5 participants through the study with no safety concerns, we actually increased this, and so that has left us with 8 on that more conservative criteria and 7 of the 15 who reported greater than 16 days use a month. So what does this mean for feasibility? Essentially, we have been able to recruit eligible participants. 15 out of 57 converting to recruitment is not a bad number comparative to other studies in this field. Most importantly, of those that began treatment, all except for 1 have completed the intervention. So the 1 participant that hasn't completed wasn't able to start their dose day as they struggled to achieve abstinence in the 2 to 3 days prior to their dose. So obviously changing the days use per month inclusion criteria has increased the generalizability of the study, but it's also added complexity to supporting participants through to manage that 2 to 3 days abstinence prior to the dose, which is obviously really important for many reasons actually. But also as a result of that, we've had 2 participants who have completed the intervention who did a scheduled inpatient detox prior to the dose day. We've had no serious adverse events. Of interest there, we've had 6 adverse events that were possibly or probably related to the study drug or the intervention itself, but they all resolved. They were essentially nausea and headache. Interestingly, I think the MRIs caused more people distress than the study drug itself. We've monitored blood pressure at hourly intervals on dose day. And while we have seen a peak around about 2 hours with a substantial increase after the study drug was administered, no medical response has been needed, and all participants' blood pressure has returned to baseline by discharge at the end of the day. Really important for this population, we've seen no evidence of a change in presentation that would indicate emerging psychosis measured using the BPRS throughout the whole intervention, but obviously particularly after that dose day. And there was no increase in severity of scores on the DAS-21 at least. So I'm just going to quickly change tack a bit. As I mentioned earlier, no study has actually examined the type of psychotherapy that's offered alongside the psilocybin. So this means that our best attempt at a model that we're working with is really a combination of the evidence base typically used in the indication that's being treated and aspects of what was originally underground psychedelic-assisted psychotherapy. It's obviously really essential from a safety perspective that we actually do start to examine the therapy itself, or at least even begin to build in fidelity checks into protocols, which is why I'm referencing it here. So for us, this has meant that we utilised the core AOD approaches used in our STP at St Vincent's and many other similar services, cognitive behaviour therapy, acceptance and commitment therapy, and motivational interviewing. And a lot of the work that we've been doing therapeutically is sort of core drug and alcohol treatment work, even in that sort of supporting participants to get to dose day with reduced use as required. Mindfulness is a significant component with a focus on building somatic awareness. The entire approach is very much a person-centered therapy with a focus on building a genuine therapeutic alliance, and we do measure therapeutic alliance throughout the prep sessions and dose and as actually a component of safety approaching the dose day. And then there's the components that we take from the psychedelic-assisted psychotherapy models: intention setting, pragmatic prep for the day itself, safety agreements, and using those therapy skills practically to progress through the dose day itself. So our recruitment concludes in December this year. So we'll have a bit more to say soon, but for now, I'd just like to thank our research team, our therapists, and our wonderful research nurse, Theodora, who've put in a huge effort to get us to this stage.
Yes, we've got a question down here.
Thanks, Liz. Great presentation. David Hedger from Mid-North Coast. Can I just ask the measure that you used for the therapeutic alliance? What measure tool did you use?
Yes, we've used the session rating scale throughout each therapy session for that perspective, obviously from the client. And I think at Prep 2, we also do the working alliance inventory, which is sort of more of a research-based measure of alliance. And obviously the therapist's own view on the alliance that's been built and sort of the safety to progress is also considered. Yeah.
Any other questions? Thank you.
Thank you.